Welcome everyone to this session. We're really pleased to have you join us on the Let's Talk Clots virtual conference, and also to welcome Nathan Hutchinson-Jones, who is going to talk about managing a Cancer Associated Thrombosis clinic with the opportunities and challenges that brings with it. Before I introduce Nathan, can I just say to the audience, there is a chat and question and answer tools in your toolbar. If you have questions, and we really do welcome these, please can you put comments and questions in those areas, and at the end, when Nathan has presented, we will go through as many of them as possible. So thank you very much. We really welcome comments and good conversation to go. Okay, so Nathan is a lead pharmacist for thrombosis and anticoagulation at the Royal United Hospital in Bath. Nathan trained in Cardiff University and gained experience working in a variety of roles in Gwent and Newport, and then came to Bristol. And it was while he was working in Bristol that he was involved with a project that I recall, the Don't Wait to Anticoagulate. Although this was looking at optimizing anticoagulation for patients with non-valvular atrial fibrillation, it was a project which evoked Nathan's interest in anticoagulation. So it did many brilliant things, that project. Thank you. As part of his role in the RUH, he has set up a Cancer Associated Thrombosis service. And so today, this is what he's going to share and discuss with us. I'm sure will be extremely interesting and helpful. So without any more to do, I'll pass over to you, Nathan. Thank you very much.
Brilliant. Thanks so much, Jo. So I'm just going to start by sharing my screen. So just make sure that this comes up okay.
All okay.
Great. Brilliant. Yeah, so thank you so much, Jo, for that introduction. And just to say, it's always a pleasure to do these sort of talks for Thrombosis UK. And, it's a fantastic resource that I use so much in my day-to-day practice. So just to say thank you to you as well for sort of organising all these things, really. And yes, so the reason I wanted to talk today was a little bit about Cancer Associated Thrombosis, or CAT. And I suppose I am going to give a little bit of an overview about the background to CAT and the treatment, but I'm also going to focus a little bit on our service at the Royal United Hospital, or the RUH, in Bath. And this is a Cancer Associated Thrombosis service that we set up in 2017. So it's been going for a few years now. We've undergone a number of changes in those few years, and I know that Dr. Mark Robinson, who was one of the consultant haematologists at the RUH, helped to set this service up, and he's moved on elsewhere now, I think, to Cambridge, but I think he is on the call. So thank you very much to him as well for the help in setting this up. And again, you can see on the first slide here, I put up the picture that so myself, Mark is on there as well, and several other members of our team when we won an award at the Anticoagulation Team Awards in London for our CAT service. So extremely proud of that. So I'm going to talk a little bit about the service, and I'm going to focus on perhaps what some of the challenges have been to setting up that service and maintaining that service, and certainly expanding it as well, because there are lots, but also what the opportunities are and how actually our service at the RUH, I think, is benefiting patients. And I'm hoping that by doing this talk today, it does inspire and encourage other people at other centres to set up similar services, really, because I think this is a big sort of area which is becoming more and more in sort of focus, and I think there are lots of opportunities here, really. So this is just to say I've got a couple of declarations of interest that you can see listed on there. That's for all education and sort of presenting work. So as I mentioned just now, I'm going to start with just giving a brief overview of CAT, and I'm going to refer to Cancer Associated Thrombosis as CAT throughout the rest of this presentation, just for ease. I'm going to talk a little about what some of the issues are in the management of CAT, and I think that's important because it gives you a feel for why a dedicated CAT service is really important and what the benefits of that service can be. I'm also going to talk about the service specifically we have at the RUH in Bath, and again talk then about what some of the future opportunities and challenges could be. So CAT refers largely to venous thromboembolism, or VTE, primarily proximal DVT or pulmonary embolism, PE, We know that VT is a major complication of cancer, affecting up to 1 in 5 patients with cancer, so a lot of patients. CAT, in the broader sense, can also refer to other types of thromboses as well. So certainly at our CAT clinic locally, we also see patients who have, for example, distal DVT, intra-abdominal venous thromboses, or indeed cancer-associated stroke. And also as well, things like PICC line-associated DVT and superficial vein thrombosis. So the overall umbrella incorporates quite a lot. And I think this is one of the first things to highlight, is that there are lots of challenges of managing these patients, because some of these patient groups are not actually, the guidance on how to manage them is not very well defined. And actually having a service which manages and follows up these patients, particularly those ones where there's not much evidence on how to manage them, can be really helpful and important. We know that patients with CAT are at an increased risk of recurrent VT and major bleeding. And the important thing is to highlight that patients with CAT are different to the normal VT population. So it is important because of that, that specialist services and clinicians have an input here to help manage these patients, because they are different. CAT, we also know, is associated with increased mortality rates and morbidity, and I think it's the biggest cause of mortality after the cancer itself. So it's a big complicating factor. Unfortunately, we also know that the information given to patients around CAT is actually often very poor as well. So patients are often not very well prepared for when they do develop a CAT, and often are very shocked with the diagnosis or don't understand the diagnosis. So again, highlighting the importance for some kind of information safety netting, specialist input really. So what are the risk factors for CAT? So how do they differ from the normal population? So patients with cancer have lots of different types of risk factors, in addition to all the standard ones that we get with the general VT population. So things like age and comorbidities, we know they're applicable to all patients. However, cancer-specific ones, so things like the cancer itself, the site of the cancer. So we know that certain cancer types have a higher risk of VTE. We also know that metastatic disease, an advanced stage of cancer, is also an increased risk factor. Also, the treatment options and the treatment therapies that we give to patients with CAT can also increase the risk as well. So particularly thinking about chemotherapy, particularly platinum-containing agents, or thinking of oral agents, tamoxifen in particular. And then also things like surgery, as I mentioned earlier, PICC lines, central venous access, increasing the risk as well, and also hospitalization. We also know that there are certain pre-chemotherapy lab results which can also indicate potentially a higher risk of VTE as well, and we'll come on to that in a little bit. So there's lots of things really. As I mentioned earlier, certain cancer types lend themselves to a higher risk of VTE or CAT. So pancreatic cancers, upper GIs, brain cancers, lung cancers, they are usually the higher risk cancers for VTE. I think if you were to do this by actual numbers, then the graph would look slightly different. I mean, certainly from local data that we've collected, I would say that the number of patients with VT is probably highest in sort of breast or perhaps prostate cancer. And I think that's more related to the number of patients rather than the percentage of patients according to the cancer type. But as I said, pancreatic, certainly very high risk. And just a note on pancreatic, I'm going to mention about treatment options in a second, because again, with the treatment options, we're now very fortunate in some ways that we have more options to treat our patients with CAT, particularly the direct oral anticoagulants, or DOACs as I refer to them, as an alternative to low molecular weight heparin. However, in many ways that has also made it more complex, and I think again highlights the need for specialist follow-up and management of these patients, because not all patients will be appropriate for DOAC. So decision making on the most appropriate choice of anticoagulant can be very important. And I mention it here because pancreatic cancer in particular is a cancer that I feel wasn't necessarily well represented in the DOAC trials, and they tend to be patients that are particularly prothrombotic. And certainly in my practice at the RUH, I tend to stick with low molecular weight heparin for those patients, and actually we often use dalteparin, which as our low molecular weight heparin of choice, and I know that will differ depending on where you are. But dalteparin, in terms of its licensing for CAT, has a dose reduction from month 2, and we tend to keep patients at full dose. So I just wanted to highlight that within these different cancers, they can affect your choice of anticoagulant really. So we know that in a patient with cancer, the risk of CAT or VT varies with time. Usually when patients are first diagnosed, when they sort of start their chemotherapy, have lines inserted, that's often, we often see a peak in risk of CAT, which normally then trails off in patients who go into remission, but certainly increases again in those patients who develop metastatic disease and approach end of life. And they can be very difficult. They can be different scenarios in regards to managing anticoagulation and thinking about patients who have metastatic disease and are at that palliative end of life stage. Well, actually, we know that treatment goals can change in those patient groups. So again, what you're going to do to manage those patients can alter. And I think, again, that highlights the need for a specialist service which can make those decisions to support patients within that patient group. In regards to duration of anticoagulation, then I think most guidelines would recommend 6 months of anticoagulation for a CAT. Now, NICE says that 3 to 6 months. Certainly, there are some patient groups where 3 months may be deemed a more appropriate duration. So in my own practice, that may include patients who have had a distal DVT and where their cancer is resolved, or a patient with a PICC line DVT where their line has been removed and they've received 3 months of anticoagulation. So 3 to 6 months, but the majority of patients, so thinking about patients particularly with things like proximal DVT, pulmonary embolism, we would normally treat for 6 months. And again, importance for review and follow up with a specialist kind of service at that 6 month mark, or 3 months, depending on the patient. It's that decision making about the need for ongoing anticoagulation. And that can involve lots of different things, but certainly one of the main factors is their risk, their ongoing cancer diagnosis if they still have active cancer. And indeed, that in itself can be difficult to assess sometimes. And with our service at the RUH, it's important to involve, we involve regularly the oncologists as well, because particularly around that decision making on ongoing anticoagulation, because sometimes you need that input about assessing what their ongoing risk is posed by the cancer. And certainly we've had some patients, for example, where their cancer is resolved almost, but they've got a very high unlikely risk of recurrence within the next couple of years. And that sometimes can maybe a factor in your decision making about continuing even potentially a low preventative dose of anticoagulant, again balancing up with the risk factors for bleeding. So really complex decision making there. And as I said, treatment as per NICE says that you can consider a DOAC now instead of low molecular weight heparin within particular patient groups where there is a low risk of bleeding. So just very briefly, thinking about other guidelines, very similar really. They consider 6 months usually as the main duration of treatment, which is slightly different to the general VT population, where 3 months now became the mainstay really. So there's a slight difference there. So just to mention a little bit about low molecular weight heparin. So for a long time, low molecular weight heparin was the gold standard really for the management of CAT. And when we set up our CAT service at the RUH in Bath, this was in 2017, and it was just before really we had the first randomized control trial, which was Hawkeye, which looked at edoxaban versus low molecular weight heparin. So our service really was set up based on the fact that most patients would be on low molecular weight heparin, and thinking about challenges in managing CAT and services. Obviously now with the use of DOACs as well, it's meant that certainly our service at the RUH, we have had to look at how we adapt that service for different patient groups, not just those on low molecular weight heparin. So thinking about why low molecular weight heparin was the gold standard for so long, this largely came from trials, and particularly the CLOT study, which compared, I think that was the deltaparin study from memory, which compared it to warfarin. And essentially what they found is they found that low molecular weight heparin was better at preventing recurrent VT, and there was actually no difference in major bleeding when compared with warfarin. So low molecular heparin really replaced warfarin as the mainstay. And when we think of warfarin, there are lots of issues with warfarin anyway. I think there are so few patients now on warfarin compared to previously. I mean, certainly there are still patients on warfarin, and probably more in certain areas of the country, but certainly we know that there are issues around things like monitoring, INR control, particularly thinking around patients having anti-cancer therapies. Then we know that there are many which can affect your INR, and obviously fluctuations within your INR control then could lead to under or over anticoagulating. And we've already said that these patients are at an increased risk of VT and increased risk of bleeding. So I think putting them on then an anticoagulant where you risk supra or subtherapeutic levels may again be adding into that. So I think from my practice, I can't really think of a time when we have used warfarin actually for treatment of CAT. There have been the odd patient actually we've used warfarin for other indications where they've been fairly stable and on a medication which is sort of a long-term medication. But in the treatment of CAT, really we've sort of stuck to low molecular weight heparin and now the DOACs. So thinking about the DOACs, so a very brief overview. So I mentioned the first study, Hawk's Eye. We then subsequently have had 2 further randomized control studies as well. So that was Select-D with rivaroxaban, and then the most recent, which was the Caravaggio trial with apixaban. So if we look at all of this data together, really, the main sort of the main results, if you like, or the main overall message is that we know that DOACs actually seem to be much better than low molecular heparin, interestingly, at preventing recurrent VT. However, there certainly does seem to be an increased risk of bleeding, mainly in certain patient groups. And I think that was particularly true with the rivaroxaban and the edoxaban studies. So, for example, patients with upper GI cancers in particular seem to have a higher rate of bleeding, and also urothelial cancers as well. Now, the Caravaggio study with apixaban had a better overall bleeding profile, I think, compared to low molecular weight heparin, but again was slightly limited in, so for example, thinking about upper GI cancers, not lots of patients within that subgroup, so difficult to make absolute assumptions. In my own practice, I tend to still stick with low molecular weight heparin for upper GI cancers, so stomach, esophageal, and also tend to stick to it in urothelial cancers as well, unless, again, with both, unless the patient's really adamant they can't tolerate the injections, or it's going to have a bit significant impact on their quality of life. I think with rivaroxaban and edoxaban as well, would probably avoid in patients with intact lower GI tumors as well. But yes, so again, there are limitations really to use of the DOACs, and again, that decision making can be really important because obviously it can have quite significant outcomes for patients. So again, sort of emphasizes the importance of appropriate choice of anticoagulant and input as well from a specialist service. At the RUH, our CAT service, we don't normally see patients at the point of diagnosis. We normally follow up patients at around the 3-week mark, which I'll come on to in a moment. But what we have tried to do to try and improve initial diagnosis and management is have very robust protocols and trust guidelines, and also support for prescribers. Now, at our own trust, this is primarily the acute oncology service who see most of these patients. So we've tried to ensure that we have good links with them to provide support. And what I will say is that what often does happen, however, is if there is uncertainty about whether a DOAC is appropriate for a patient, what often happens is they will get started on low molecular weight heparin with a plan that we will review them then at that just before the 1-month mark and make a decision about whether actually they can be changed to an oral anticoagulant. There are other CAT services as well. So a colleague of mine called Kieran Power in Swansea also has a CAT service slightly different to ours, and has done lots of really good work within VT and CAT. And they have a slightly different service where they see patients at the point of diagnosis. And I think that, there arguably is some advantages of that, but it does sort of emphasize that there can be differences within, if you're thinking of setting up a service, there can be differences and you can adjust it to suit what suits you best locally. And it also depends as well what you can actually do in terms of what funding you get for setting up such a service. And certainly with us locally in Bath, at the moment, we wouldn't have capacity to see patients acutely. We can only see patients at follow-up, so we're sort of limited by that, really. So we've already talked about a little bit about duration, so I'm not going to talk about that again anymore. The other thing I wanted to briefly mention, because I think it has implications again for opportunities for managing patients with CAT and setting up new services. So this is around, rather than treatment this time, this is around prevention. So the BSH and NICE already suggest that certain patients may benefit, ambulatory cancer patients receiving anti-cancer therapy, chemotherapy, may benefit from VT prophylaxis. primarily with low molecular weight heparin, but certainly some patients locally we have used prophylactic apixaban as well. So they would particularly mention patients, for example, with pancreatic cancer. And I've already mentioned, if you remember that graph we looked at, particularly high risk of VT in those patients, but also patients with myeloma as well, who are receiving therapy with things such as thalidomide or lenalidomide. Interestingly, the ASCO, the American Society of Oncology guidelines, have also recently come out with a recommendation that we should expand that risk assessment and VT prophylaxis to a wider group of patients. And they've suggested using something called the Karana score, which I'm not going to go into great detail in this presentation, because we could probably do a whole presentation on it. But they have suggested that those patients who are deemed higher risk with the Karana score may benefit from preventative anticoagulation. And there have been studies both with rivaroxaban and with apixaban with this. So I just wanted to mention this because, again, you know, if this becomes more mainstay and more routine, then in addition to managing the treatment and diagnosis of CAT, there's probably a big role here as well in the prevention of CAT. And I think when we think of our oncology services and hematology services, they're already pushed and very limited in what they can do. And I think having a service that can help with this is potentially going to be very helpful to them, because I think certainly there's going to be difficulties in capacity in providing this risk assessment and initiation of appropriate VT prevention as well. So I've already mentioned some of these, but I'm just going to sort of give an overview really now of what I think the potential issues are in the management of CAT. So we've already mentioned a little bit about the importance of appropriate choice of anticoagulant. And even though it's brilliant now we have this data where we can use DOACs, again, they're not appropriate for all patients. And particularly thinking about DOACs as well, interactions with anti-cancer drugs are also important. And I think that's really difficult actually, because unfortunately, lots of our anti-cancer agents, there is very limited information about whether there is a significant interaction with these agents. And a lot of it is theoretical. So a lot of it comes down to understanding and looking into the pharmacology and then making a judgment call really about what is the best choice of anticoagulant. And thinking about the DOACs in particular, you're going to be particularly thinking about those agents which can affect CYP3A4 glycoprotein. We also mentioned at the beginning that we know that these patients are different from our normal VT population, and actually that they're at an increased risk of VT and of bleeding, and that varies within this group of patients. So having an understanding of that and adjusting and adapting the management, the treatment, the anticoagulation in these patients is really important. So with these patients, if they have a recurrent VT, which does happen, how do we manage them? What do we do then? What about if patients bleed on their anticoagulation? What do we do then? So all really important issues, and I think highlights how a specialist service can input there to support the wider oncology hematology teams. And then thinking about, again, patients with cancer, what complications they have just from their cancer therapy. So thrombocytopenia, how we manage things in low platelets and those at increased risk of bleeding. Nausea or vomiting, you know, maybe a patient's not going to be able to tolerate an oral anticoagulant. And fluctuations in body weight, which often happens as well, particularly important when you think about low molecular weight heparin and appropriate dosing. We've already mentioned about ensuring appropriate duration of anticoagulation. And I remember when we first set up our clinic, our service, I should say, at the RUH in Bath, we'd had incidents where patients had been started on anticoagulation and unfortunately actually stopped after the first month of treatment because that's all they'd been given by the hospital and they assumed that was it. So, you know, you can see just how like serious sometimes some of these problems can be. And these would be in patients who are particularly prothrombotic. We already mentioned as well at the beginning that CAT as an umbrella talks about not just proximal DVT and P, but also other types of thromboses as well. And they are often patient groups where there's very limited information about how to manage them correctly. And sometimes we have to make judgment calls on how to manage them based even on a low amount of evidence. We know as well that there's opportunities within management of CAT for greater involvement with primary care, particularly utilization of shared care protocols. Certainly at the RUH, we've made very good use of shared care protocols. So we have shared care guidelines in place for all for DOACs and for low molecular weight heparin, meaning that patients are able to access and get provided with their anticoagulation in the community, particularly helpful where we are in terms of geographics, because we have quite a lot of patients who are relatively rural. So that's been really helpful. And also as well from a secondary care perspective, that also results in a cost saving for us as well in terms of provision of that medication. So, so that helps as well. And I think with the shared care, I found that our GPs locally have been very happy to participate in that because they can see the benefits to patients, but also because we have a very robust system and follow-up service in place where actually GPs and patients can contact for advice. We send regular communications about ongoing management and advice, and I think GPs feel very reassured by that. And that's, I think, is when shared care can work. And it's interesting because before we set up this service, we did have a shared care guideline for low molecular weight heparin in place. But one of the things that we found when we did our initial baseline audit is that nobody was following that shared care guideline and hardly anyone knew it existed. And I think that shows that, you know, just having guidelines doesn't always work. You need to have guidelines and protocols in place, but you also need to have support and people who can be contacted for advice amongst that as well. Also appropriate monitoring, so particularly thinking about low molecular weight heparin, rechecking bloods, platelet counts. I know certainly there are patients, hematology patients we have who are particularly prone to thrombocytopenia with certain cancer types who are having certain treatments, and we'll often be asked by one of the hematologists to help monitor those platelets and adjust their medication as needed. Also things like renal function, liver function, again important with the DOACs. Also, I alluded to this earlier, but patients who are palliative, approaching end of life, they can be quite complex in lots of ways. And I've had certainly over the last few years some very difficult conversations with patients who've been approaching end of life about their anticoagulation management. And I think they can be a group of patients who can really benefit really from input from a specialist to discuss this. Because don't forget, I think the other thing is that with CAT, it is, I think it is another condition aside from the patient's cancer that needs to be managed itself, and that can be very difficult, I think, without having a specialist service involved. Also patient awareness and understanding of their condition as well, and I think that's a big problem as well for patients before they even get diagnosed with CAT. So, you know, we're not very good sometimes at explaining that risk to patients. And I think one of the reasons for that is that when a patient gets diagnosed with cancer and is starting treatment, they are bombarded with information. And I think to give them more information again around the risk of CAT can be very, very difficult. So that's something as well that really, certainly at the RUH in Bath as well, we still need to improve. By all means, we, you know, not got a perfect service. And you know, that is something I think on the wider scale as well that needs to be improved. And certainly there has been lots of research done which has shown that variation in the management of CAT has caused lots of problems for patients. And certainly there's been a disregard and lack of awareness of guidelines when they've been implemented, which is what I've mentioned earlier. And certainly given the complexity of the issues around the management, that is really reason why specialist services and clinics have been set up, like the one at the RUH in Bath and the one of my colleague in Swansea. And we've certainly based a lot of our work on work that was originally done by Professor Simon Noble in South Wales at Balindra, you can access the paper they looked at where they set up their service online for free. And that was a really good starter because they did a lot of this groundwork really to highlight these issues. So talking about Simon Noble, actually, he also has done another, lots of studies, but another one I wanted to mention called the Pelican study, which is a really interesting read. It's free to access, but this looked a lot around patient experience of CAT and basically highlighted this, that patients had this limited knowledge about CAT and hadn't been receiving information, which is what I'd mentioned just now. They also weren't aware of what they should be monitoring for, red flags, and a lot of these patients really had found their CAT journey very distressing, really, with a lack of information and support, and certainly a big lack of ownership for management and ongoing safety netting, really. So this was a lot of that initial work which led Simon Noble to set up a service, and as obviously subsequently meant other services like ours at the RUH was set up. So what are the benefits? So, well, all of the things we've just talked about are things that could be addressed really by a CAT service. It's also an opportunity, I think, for allied health professionals to be involved with. So our service here at the RUH Bath at the moment is pharmacist led, but previously we have also had nurses involved with that service, and that has worked very well too. I believe Kieran Power's service in Swansea is also pharmacist led, but this is a service that could be adapted really to suit local needs. So nurses are the other group of professionals that come to mind, but I'm sure there are other groups of people as well who may be well placed really to be involved with this. And certainly it helps if you have someone who has an interest in this, so they're probably a good person to sort of take a lead on it really. I've already mentioned about the uptake of shared care, safety netting and support, and also support to other healthcare professionals. So I certainly think that since we've set up this CAT service at the RUH in Bath, I like to think that we have helped upskill as well wider members of the oncology hematology team, particularly thinking about people in our acute oncology service, our oncologists, registrars, SHOs, nurse practitioners as well. So I really think that, I do think that having the service has meant that everyone has been more upskilled and been better placed to manage these patients, particularly thinking about all of the information that has come out over the last few years, really, particularly with the advent of the DOACs. And also as well, I think it certainly has really helped. So thinking back to what I mentioned about variation, I certainly think with us locally, it has meant that our practice has become much more standardized, and that has helped really. And it's also meant that our practice is being based on the most up-to-date evidence, where at the moment where things are changing all the time is really, really important. So this was the Simon Noble study that I mentioned. So we obviously already talked about the Pelican study. So this was the study that they did after they implemented a specific service. And essentially, this was a different model to the one that we have at the RUH in Bath. And so this was led by a palliative care consultant with specialist nurses, and basically worked really well. Again, this was set up at the time where low molecular heparin really was the mainstay of treatment. But certainly they had really good outcomes where there was lots of referrals, a big increase in safe and consistent prescribing of medication for appropriate durations, and with patients showing a better understanding of their condition and enabling them better really to self-manage and having access to that sort of support and information that they needed. There was also a much better understanding from clinicians as well, awareness of guidelines, etc. So to talk a little bit now about specifically the RUH service at Bath, which is the service that I myself helped set up in 2017. So as I said, this now at the moment is now a pharmacist-led service. So you have myself as a Band 8A pharmacist and lead, with support from a rotational hematology oncology pharmacist. And the way we funded that, so which might be interesting for some people. So my post was funded initially through an external grant from Pharma, and that was for a 12-month, so it's pump primed essentially for 12 months, with the aim of optimizing anticoagulation services, and that was done through hematology. And during that year, one of the things we focused on actually was CAT, and I'm very glad we did, because obviously it resulted in us setting up the service, but also resulted in my job being made permanent because of the work that we had done, partly through setting up the CAT service. So things like improving patient safety, reduction, cost savings, uptake of shared care, etc. So that was the way we went about it. And then in terms of expanding the clinic and ensuring that I had support, how we did that was, so I'm based within hematology, and part of my time per week I use to support the hematology oncology pharmacy, where I support with screening chemotherapy agents, things like that. And as a result of that input from pharmacy, then we've had some backfill for that time from a rotational pharmacist to support the CAT service. So that is how essentially we've managed to do it. And as I said, it does mean that at the moment we're limited in what we can do. We can't do everything we would like, but certainly it has meant that we have a robust follow-up system at the moment, which is obviously brilliant, and I'm very grateful to have. And we also have support from a consultant hematologist as well, particularly for very complex patients where we can discuss them as part of an MDT. And obviously we also have input then from other health professionals, including the patient's oncologists. The way we set up the clinic is as a telephone clinic. So obviously through COVID, this has become more, I think, more routine now for patients, but we actually chose to set it up as a telephone clinic before COVID. One of the reasons for that was we found that patients, we did a lot of audit work, which I'll come on to, but we found a lot of patients were coming back and forth the hospital for different appointments, and a majority of patients said they would prefer a telephone appointment. So because we weren't doing the initial diagnosis, but we were doing a follow-up, we felt that we could manage that on telephone, and we had very good responses actually for doing it via telephone. So that's generally what we've stuck with overall. We have had some patients where they'd have preferred face-to-face, or where we felt that might be appropriate, but what we've managed to do is we managed to tie that in when they've attended, for example, to receive chemotherapy, or they've come in for an appointment with the oncology team. So we've managed to sort of work that in for individual patients if needed. We've also found that by setting up the service I mentioned earlier, we've managed to give a lot of support for healthcare professionals within the trust, and we've implemented a lot of trust protocols, guidelines, shared care guidelines as well. So just a brief overview of that structure. So patients can be referred to our clinic electronically. So we have EPMA, which I think a lot of secondary care trusts now would have. We also can have referrals come in from primary care as well, though it doesn't tend to happen very much, because I think certainly locally, a lot of these patients will come through, if they've got a cancer diagnosis, they will often come through either the acute oncology team or the front door of the hospital. We will then normally process that referral, send a letter to the patient and GP to say that they have been referred, and then we will see them just prior to their first month of treatment, at 3 months and at 6 months. And at each of those consultations, we will adapt that to match whatever the patient needs, but we will have a general standard checklist. So our 1 month review will be slightly different to our 3 and 6 month. Obviously, the 6 month review for most patients will mainly be about the need for ongoing anticoagulation, whereas that first month review will often be more focused on what they're currently anticoagulated with. Are they tolerating it? Have they got appropriate management plan in place? Have they got everything in place for ongoing supply of medication and appropriate monitoring? So there are differences with each of those, really. And obviously, I should have said within that as well, there may be some patients who need more follow-ups, and there may be some patients who need less follow-up. So it's kind of not really, that's a general overview, but it doesn't always fit every patient. So I think you have to be a little flexible there. And I think certainly thinking about now all the different treatment options we have and the different types of patient you can have, I think we do have to adapt things to try and individualize really our follow-up. So looking at specifically our baseline data, so we've obviously mentioned lots of the data that was collected by Simon Noble and the work done with his team. So we did our own audit as well locally. So we collected information over a 3 month period, and essentially what we found is that the management of CAT locally was unsafe, and it was certainly very, very inconsistent. And now again, this was back where really nearly all our patients were on low molecular heparin, so it is really focused on that. But certainly we found lots of patients, so dalteparin has a dose reduction after the first month, which we would use for most patients with CAT, though not necessarily all. We found lots of those patients weren't having appropriate dose reductions or weren't on the appropriate dose according to their weight. We also found that there was very poor communication between secondary care and primary care about choice of anticoagulant, treatment duration, and ongoing monitoring and management plan. And as I mentioned earlier, there was a lovely shared care guideline which nobody was using and nobody seemed to know about. So there were lots of problems. So as a result of this audit and the other work that Simon Noble had done, we decided really that this was we needed our own service to be set up. So once we had sort of trialed and set up the service, I will say that this will probably be of interest to people who are thinking about setting up their own service. We actually went, so what we did, as with any project, we identified the key stakeholders within our trust, spoke to the oncology team, highlighted all of the issues, and essentially gained the support from the people we needed to trial this service. And actually, we were very fortunate in, I think certainly our oncology team could see that this was a big issue and certainly needed to be addressed. And we're very supportive of setting up a service. So we did trial a service and we reassessed things after a further 3 month period. And we saw big improvements with patients in terms of patients being now anticoagulated with an appropriate dose reduction after 1 month in appropriate patients, communication of treatment plans, management and monitoring, uptake of shared care, and also some cost savings as well for our pharmacy and secondary care. So it was very, very positive, really, and certainly all the feedback we gained as well from patients was very, very positive as well. We also made quite a few interventions. So over the 3 months, we had documented 16 interventions, and they range from lots of different things to do with intolerance to low molecular weight heparin, recurrent VTE, post-thrombotic syndrome, thrombocytopenia, clot extension, adverse reactions, and supply issues. So they just give you a feel for some of the issues that we picked up during those 3 months, and certainly ongoing issues which we see now. And you can see that I've just put some quotes as well from the feedback from the oncologists as well, which was really, really positive. And it was this data really that helped us make this service a permanent fixture, really. So we've obviously continued since then, and just to give you an idea of what the service looks like at the moment. So thinking about the 2021 so far, so in terms of patient numbers, we've had around 94 patients referred to the service over an 8-month period. Those are predominantly oncology patients, but with some hematology. I think locally, a lot of the hematology patients, we do tend to get followed up with the hematologist. So I think they don't always necessarily need additional input from us, but you know, we get involved if needed. And sometimes we will be asked just to help with platelet monitoring, for example, rather than an official follow-up. So again, I think that highlights, doesn't it, the adjusting the service to meet the demands that are on you. And certainly we have seen over the last few years increasing numbers of patients on DOACs, and how obviously we follow up and manage those patients has changed from low molecular weight heparin. And certainly, as I mentioned earlier, we have a lot of patients who are referred to the service initially on low molecular weight heparin and essentially asking us to make the decision about whether they can be changed to a DOAC after they've been seen. And we also see lots of different types of thromboses as well, not just sort of proximal DVT or P, sort of thinking about other areas as well, which I mentioned earlier. So hopefully, I think I have highlighted what the benefits of a service could be, and how certainly we set up our service at the RUH, and some of the problems that can happen within CAT, and you know, the reasons why a dedicated service can be beneficial. In terms of opportunities going forward, I think certainly what I would hope is that this is becoming a hot topic, if you like, more and more as time goes on. And I'm hoping that in the future, we'll see more CAT services set up. And I'm sure we will see lots of different examples of how such a service can be set up and how they run. And I think, you know, I'm sure like the service we have at the RUH, we'll be able to learn from other people as well and adapt our service. And I think I would like to hope that this does promote allied healthcare professional involvement with this as well, particularly pharmacists. Obviously, being from a pharmacist background, that would be really, that would be great. And I think at the moment, you know, the other option, obviously primary care involvement is, with lots of different things, is becoming more of a focus. And I think with CAT, there are some difficulties in that it's tended to be secondary care managed, because that's where patients tend to go for their cancer treatment is being managed in secondary care. But certainly I think we've highlighted that uptake of shared care and supply of medication has been something that has been had a good uptake with us locally in primary care. And I'm sure there are probably opportunities there as well to expand and increase the role of primary care. As another example of that, actually, I think there was a study that was done in Canada where they had a community pharmacy service where they were providing follow-up for patients initiated on low molecular weight heparin with blood monitoring. So that's one good example. So there are lots of ways that this can be done. And then when we think about existing services, there are certainly ways in which we can expand, and I've touched on that already. So thinking about VT prevention in patients at risk of CAT, also greater involvement perhaps in initial diagnosis, if that's what suits you know, you locally. And certainly there are some services which do that. So thinking about my colleague Kieran's service in Swansea, they are more involved. They see patients acutely at the point of diagnosis. And certainly there are going to be lots of, I think, further interesting developments and research opportunities within this area. And, you know, it's a good opportunity for people to get involved with. And if if we're setting up more of these services, there's also opportunities to collect real-world data as well, which can obviously be used essentially to better guide our decision-making, particularly thinking about all those patient groups within CAT who actually have still limited evidence to support the best way to manage them. So yeah, lots of opportunities, hopefully, and I hope it has sort of helped encourage maybe some people to try and look into setting up services of their own. However, as always, there's always challenges to this. And I think one of the ones that, thinking about our own service at the RUH, I mentioned a little bit about sort of getting initial buy-in. And I think we didn't really have much of an issue with that in terms of clinicians, but certainly in terms of funding, that was more difficult. And the other issue with us was ensuring, so we had myself who was running the service, but trying to ensure that that service was robust and backed up. So rather than having a one-man band, and then if I got knocked over by a car, for example, there would be nobody to manage, there would be no one to manage the service. So having that backup and trying to work out how you can do that, even with limited funding, can be difficult. And as I mentioned earlier, the way we did it was by essentially me using some of my time to work as part of the wider hem-onc pharmacy team, and then having one of the rotational pharmacists to essentially backfill that time and support me with the CAT clinic. So that's one example of how you could do it, but I'm sure there are lots of ways. So certainly developing business cases and accessing funding can be quite difficult. But I do think there is a lot of information out there now to suggest that a CAT service can be beneficial, not just the information that I've given you now from us at Bath and also the Simon Noble information, but also if you were to collect information yourselves at your side locally, I'm sure that would be helpful as well. And I think the other thing as well is just also ensuring that we have adequate training and support for staff involved with that service, and we're not necessarily de-skilling people either. So I think there's a fine balance there, and that can also present challenges. So I think in the future, it may be that we have certainly more sort of national training guidelines, things like that. That would certainly be beneficial. So I think that was it. That was all I was going to talk about. So I think I finished with about 10 minutes to spare. So that was quite good timing, Joe. I don't know how that's happened, but I just wondered if there are any questions. Oh, by the way, if I'm happy for people to email me or anything if they want to, by all means, give me a shout, and I'm happy to have a chat in a bit more depth about anything our service at the RUH or anything we've talked about. But yeah, just if there are any questions, Joe, or if you thought that was okay.
That was brilliant. Thank you very much, Nathan. And yes, there are questions, but firstly, thank you.
You're welcome.
If I just go through the chat service first, because quite a few put questions in there. So
great.
How long did it take to commence the CAT service at Bath?
So actually, we set it up relatively quickly. I think so. We managed to set up the CAT service within the first 12 months that I was at the RUH, and I think one of the reasons we also managed to do that, because there was some slight time pressure, because I mentioned earlier that my post was initially funded temporarily through external, so there was quite a pressure to show that my post was needed and was beneficial. So we did manage to do it quite rapidly. As I said, our initial baseline audit was for 3 months, and then we probably spent another couple of months analysing the data, feeding it back and arguing the case, and then another couple of months probably setting it up, and then another couple of months auditing. So it probably was about 12 months all in all that it took for us to set it up. And I think, in terms of whether that would be the same for other people, I suppose it depends, doesn't it? It depends what support you have and what, if you have a thirst for this locally, or it's already an established need, then obviously it's going to be easier. But it can take some time to work out how it will work locally. And I remember a couple of times sort of sitting down and process mapping and trying to identify how we could adapt things locally, because certainly a one size fit all isn't going to always work. So I think if you get maybe good buy-in at the beginning, and you understand what you're trying to do, and you identify how best to do it, then actually that will help with how quickly you can get that service set up, I think.
Yeah, brilliant, thank you. And you mentioned obviously Simon Noble's work and his clinic, and then Kieran Powers as well. Mm-hmm. But Is there opportunity or anything available that is either in an international network, because obviously we've got people joining this meeting from across the globe, or even a national network where people can discuss setting up and even some of the challenges that they might be facing in their own CAT service? Is there a network that's now being developed, established?
That's a great question, isn't it? And it's a great idea. I'm going to write it down after this because that is exactly what we need, isn't it? I mean, thinking about international wise, so the ISTH really has got some really helpful, just thinking about upskilling and train. I think it's got a training package actually on CAT, which I don't know if you need to be a member to access or not, actually, off the top of my head. So I don't know if you know, Joe, whether you, I'm not sure, but
I'm not sure. I think you might have to.
Yeah, but anyway, there's got some really good training material and resources, and there are also, if you have a look in sort of like do like a bit of a literature search, there certainly are other models of CAT services being set up, and I mentioned one about a community pharmacy service being set up in Canada, and I think there's another example as well of a CAT service which was set up. I think this was in the US. I think most of what I've seen outside of the UK has been in the US and Canada, and I think actually there's some, certainly in Canada, I think their thrombosis sort of group is quite heavily involved, I think, with the ISTH, and they've done quite a lot of work. And I know Simon Noble has done quite a few different things around CAT jointly with them. So, but I think in terms of promoting CAT services and sharing help and advice to people about setting up these services, I don't think there is necessarily a group where you can discuss that. I mean, certainly there are, thinking about pharmacists, we have things like the UK CPA, which is a pharmacist organisation, and we have within that a thrombosis anticoagulation group where you can discuss things. But I think, specifically, if we're thinking about a multidisciplinary, CAT-based discussion forum, if you like, where you can share ideas and things like that, I don't think that exists. If it does, by all means, somebody let me know. But I think that's a fantastic idea, and maybe as more people, I think as CAT services become more routine, because I think they will now going forward more and more. I think it's happening over the years. These are becoming more routine. I think there will probably be, there'll be more of us to help perhaps set those kind of things up. So I think it's a great idea, and yeah, I'd love to be involved with something like that, actually.
And you certainly said that you are happy if people feel that would like to email you, and your email's still on the screen. So if there's questions, whatever, because somebody's asked also about getting started, the real basics of planning, logistics, resources. What are the initial first things that you found really helped you to get going?
I think just, first of all, just establishing if and what the problem is, because I mean, as I said, we had to establish that there was an issue locally before we could really do anything, because I don't think anyone was really going to buy into it unless, because as you said, I mean, we've talked a lot about work by Simon Noble and what we've done here, but I suppose somebody could very well turn around and say, well, actually, I think we manage it quite well here at our, wherever we are. So why do we need this? So I think if you can say, look, there is a problem, this is the problem, we need to do something about that. And some of the data you can collect can be really strong, and be really impactful. So I think that is really, really helpful. And I think the other thing which can help, so certainly I remember doing a lot of work with our sort of quality improvement team at the RUH, and again, thinking about things like process mapping, service evaluation, improvement projects, PDSA cycles. There are actually lots of resources available. I think if you work in secondary care, then there are lots of resources actually within the hospital who can help you with that. So, and I think also identifying key people who are enthusiastic about this, particularly people who are influential and are going to make a difference and help you get this through. So with us locally, we were very fortunate. We had two consultant hematologists who were very on board at the time. We had consultant oncologists, the lead consultant oncologist who was very on board. We had lots of people, patient safety lead, we had lots of people who were really on board with this. And that helps, that buying helps, because it gives you then, it gives you the power to push it through and to get it done. Because I think, otherwise it can be very daunting. And certainly as, coming as a pharmacist, it can be hard sometimes to make those big changes without that buy-in. So I guess they would be sort of my tips, if you like, and also to make sure that you have, to make sure if it's going to be you, that you've got the time and you're the person who wants to lead on this, because somebody has to lead on this and take ownership for it. So, and it is a lot of work as well. So I think if you're going to go for it, then you have to really sort of go for it.
Yeah, I think so. And I think, as you say, it's such a multidisciplinary team.
Mhm.
But as you've shown through your presentation as well, it's upskilled people across that team in those departments as well. And do you think it's, from a thrombosis point of view, also raised the profile of thrombosis across the hospital because they've seen teams working in collaboration and the benefit that it's brought?
Oh, definitely. Yes. Without a doubt, I think it certainly has. And I suppose, what you're getting at there as well. I mean, not just CAT, is it, but just thinking in the wider context of BT in general. I think certainly probably more, I'd like to think that more people within our trust are more aware of the risk of BT in general. And then certainly, with our CAT service, I think our oncology teams, and I mean, I think they're very hot on VTE now. Because we talk about it all the time. We've got a service, and I think that it does really, really help. And I think if you're someone who wants to champion not just CAT but BT in general, then be that person, because it really does help. And sometimes I think it can feel very daunting feeling like you're the only person, but if nothing else, you don't have to have a big team around you, but sometimes just by you being enthusiastic about it and talking about it, you actually can, as we said, upskill other people to be thinking about it at least, and to be more conscious of it and to be involved with it. And so that is something you can do even if you haven't got lots of funding for a big team of people. I mean, as I said, we were only a small team at the RUH, but we probably managed to do quite a lot with just a small thing, really.
And that also examples that actually you could be a pharmacist, or you could be a nurse, or you could be in another role, but it
Oh yes, yeah.
would work with that passion and willingness to work with others.
Oh, absolutely. And it depends what, as I said, there will be people who are in different roles. I mean, I think a pharmacist role works great for this, but there will be people who are in other roles as well, where actually they're perfectly placed for this. They've got the skill set already, maybe they've got the interest there. They're positioned well to manage to set up a service. So yeah, absolutely. I think there's a lot of flexibility there. And I'd be very interested to see what other services people set up, really, and see how they work, because they'll give me ideas as well. So
I was interested to hear also how you'd been able to work across to a certain extent with primary care as well, which was, and there were two sort of feedbacks added to the hospital one from primary care and one from patients. So looking at primary care first, how did you find that work best to get them involved, but also make them aware of you?
yes, so I think, yes, initially we did have to do quite a bit of work around, I suppose, establishing our service and our visibility, and we are here, XYZ. And when we first started, we did have a little bit of, that sometimes there are a few GPs who would contact us back and just confirm with us what was happening, XYZ. And we had a lot of correspondence with GP networks and the CCG about accessing shared care guidelines where they were. And what we also found very helpful was when we started our service. So on our letters, we at the bottom, even now actually, we have links to all our shared care policies and links with primary care, and we've updated them since we've been in, so they're all up to date. They're all very, very clear about responsibilities, and I think my finding is that with the shared care side of things, then people almost always are happy to be part of that, but they just want assurances about who is, somebody is looking, they're not just being left to do this, and nobody is looking after them from secondary care. But I think there probably are opportunities even outside of that, and that is going to be something that we probably need to look at. I mentioned a bit earlier about the community pharmacist service, where they were doing blood monitoring for patients after they've been initiated on low molecular weight heparin, so checking things at like 5 or 7 days and checking like platelet counts and things and technique. So there definitely are opportunities there, and we probably really do need to be utilizing that, and there's a big push with lots of different things, isn't there, about more care and primary care closer to home, things like that. So there are probably lots of things we need to think about. I mean, I don't necessarily know what they all are, but I'm sure hopefully there are some people who have really good ideas. And the other thing is we also get quite a lot of queries from practice pharmacists about CAT patients as well. So certainly locally at the RUH in Bath, we've been fortunate in that, so I've managed to develop quite a good working relationship with our GP practice pharmacists in the local area. I've done training and teaching on different areas to do with anticoagulation, and they have basically our contact details where they can contact us for advice. And certainly we've had, it's usually less so with the CAT patients, but not always. And certainly they've been often people who have flagged to us actually, you saw Mr. Jones on the so-and-so, actually they've turned up and they're really now struggling with the injections, and I've looked at their stomach and they look awful, like, oh, actually, is this something, and I find that they often pick up these kind of issues. So I guess having that contact, because the people in primary care are often the people who see these patients as well, regularly as well, and sometimes they pick up these things. And as I said, not all patients will be, you have someone who's having chemotherapy, for example, and they're back and forth the RUH quite a lot, or the hospital. But there are also some patients who aren't having cancer therapy and are at home quite a lot, or they, so it's trying to identify who these people are who are going to be seeing them regularly, having those contacts and being able to sort of all work together so that you can manage them.
And you also mentioned that patients certainly gave really positive feedback. What do you think are the key benefits that they've gained or they've fed back on that they've liked?
So I think the key things have been having someone who is taking responsibility for managing it and giving them reassurance. I think a lot of patients are often very anxious about it. I mean, for example, we'll have patients where they've had a CT staging scan, they've been rung up and said, oh, actually, there's a blood clot in your lung, you need to come to A&E. They come to A&E, give them some injections and send home, and that's about it. And then they're just sort of left worrying, basically, at home. So I think, yeah, we've had lots of good feedback about reassurance. I think safety netting, having somewhere you can contact and speaking to people who know about the condition. I've had, a few patients where sometimes they get a little frustrated where they've perhaps spoken to someone else and they don't know very much about it. And then, so I think they like having someone who knows what they're talking about, really. And I think people also like that it's someone who, someone who is working alongside and in conjunction with their oncologist as well. So I think that's important for patients as well, that you'll be seen, you're working as part of that team and alongside them. So you're not a completely separate entity, as it were. Because the cancer patients with CAT, I think most patients, they would still say that their cancer treatment is still their priority. But yes, and I think the other thing as well is, sort of provision of medication as well. So ensuring ongoing supply and, knowing that if they do have a problem, they can contact someone, and actually, things like how long they're going to be on it and why they're being on. I mean, there's so many things, Joe. It's, I think there's lots, really. Yeah.
You're right, that reassurance and that communication across disciplines, it for that patient must be so valuable, and that will relieve a lot of anxiety as well. Yeah. A message, and probably a good one to end on as we get to 3 o'clock, but from Mark Robinson, who praised a brilliant talk, definitely. He says, now, his question is, where next? Can you see the model running over any other area of thrombosis, such as unusual sites, vasculitis, and paediatrics?
Yeah, I think that's a really good point. And I think, yes, certainly it is a model that I'm sure that you can adapt and use for other areas. And so, Mark has mentioned a few there. I suppose the other area may be sort of thinking about BT within pregnancy as well, for example. I know certainly that's an area where locally we've struggled, actually. And again, it's interesting, you look into it and it's similar issues, lack of follow-up, lack of ownership, lack of continuity, provision, supply of medication, very similar issues. So yeah, I think absolutely these could be follow-up. And I think some of the areas Mark mentioned, so some of those are obviously areas with very limited evidence. And I think those patients sometimes can be really difficult to manage, and probably some of the patients where they would really benefit from follow-up. And certainly thinking within our CAT clinic, actually, interestingly, a group of patients which I think have really benefited, not necessarily a group where their risk of VT is really high, but I'm thinking along the lines of superficial vein thrombosis. So, a relatively minor in terms of thrombosis type, but actually a group of patients who largely don't get any support or management at all, and they're just left really worried and concerned that they've been told they've got a clot, but they don't understand anything about it. So, and again, an area where sometimes there's less evidence on how best to manage them, particularly in the context of cancer. So yeah, I think definitely this is a model that can work in other areas. And I hope this, this model I've described is not, it's not set in stone. This is something that needs to be adapted and changed. And, I just hope it just encourages other people really to think of their own ideas. And going back to what your first question about a forum or discussion area where you can share these ideas, I mean, that would be fantastic, wouldn't it? So hopefully that will be something that we can do going forward.
Yeah. Nathan, inspirational hour with you. Thank you so much.
Oh, you're welcome.
For everybody who's joined, this session it has been recorded and will be available from tomorrow. But yes, thank you everybody, and we look forward to seeing you at the future meetings on the Let's Talk Clots platform. Thank you very much.